Welcome everybody to CRS Virtual Education. We are recording the session and playing live on Surgeon as well. Tonight we have joining us Dr. Soriano, who I am happy to introduce, is going to be talking with us about ergonomics in colorectal surgery. He is an associate professor and director of robotic surgery in the Department of Surgery at the University of California, San Francisco. He's also chair of the education committee of the Society of Surgical Ergonomics. He completed a combined undergrad and medical school program at the University of the Philippines, trained in general surgery at Mount Sinai in New York and Einstein Medical Center, followed by a fellowship in MIS and bariatric surgery at Cleveland Clinic, Florida. Prior to coming to San Francisco, he was chief of gastrointestinal surgery and surgeon champion of ACS-NSQIP at Pennsylvania Hospital, as well as associate professor of clinical surgery at Perelman School of Medicine, University of Pennsylvania Health System. He's a fellow of the American College of Surgeons and was awarded honorary fellow of both the Philippine College of Surgeons and Philippine Association of Laparoscopic and Endoscopic Surgeons. And so with that, we'll let you take it away, Dr. Soriano.
Thanks so much, Gabby. Good evening, everyone. Thank you for joining us tonight. For those on the West Coast, it's mid-afternoon on Sunday, and hopefully we can get you guys out to dinner pretty soon. Just going to share the screen and let me check, make sure everyone sees it, and switch to this view. All right, is everyone seeing this now? Are we good, Gabby? All right.
Yep, good to go.
Excellent. So I know I probably won't be able to see a show of hands, but as fellows now, having finished anywhere from 5 to 7, maybe 8 years of general surgery residency and about a couple of months into your fellowship, I was wondering, just think to yourself, ask the question, how many times have you felt aches, soreness, or pain at the end of your OR day in your neck, back, shoulders, or wrists? And I was really hoping I'd be able to see a show of hands, but at least just think about this as you are going through this talk today, and hopefully at the end of each week, think about this, and hopefully that number will go down with each week. And then second more important question, I guess, is how many of you stretch or exercise? Before cases, at the start of the day, at the end of the day, after cases, between cases, and also at night. And finally, on weekends. And I think it is important to know that, as surgeons, we try to have a good, as you say, work and life balance. But it is important to, I think, recognize that a lot of what we do in our lives on weekends, after the day, especially in terms of exercise and being active, can affect our performance in the operating room. And that is why I think when I was being asked to give this talk, I thought it was important to talk about, post-op pain. But in this case, the post-op pain I'm talking about is not for the patient, but for surgeons. Because I think a lot of it of us, as we practice, if we do not do it with proper exercise, stretching, and most importantly, doing it in the right neutral positions, can suffer from significant post-op pain, particularly, I think, colorectal surgeons, because of the number of platforms that colorectal surgeons operate in. You've got open, laparoscopic, robotic, TAMIS, as well as performing endoscopy. This is my disclosure slide. None of this is relevant to the material being presented today. Some additional disclosures. I'm a middle-aged surgeon who wears a size 7 glove. And historically, my back, shoulders, elbows, wrists, and knees would hurt or ache after a full day of laparoscopic cases. And I thought that sitting on a chair with my head on the console would help. But at the end of the day, I still get aches and pains in my back, ankles, and wrists after a full day of robotic cases. So today, our goals are increase awareness and the practice of ergonomic principles in the operating room, learn ergonomic positioning for various colorectal procedures, and also understand the importance of intra-op micro breaks and stretches. We're going to break down the talk into four. We'll talk about definition and principles, followed by the significance of ergonomics. And then I guess the meat of the matter, we'll talk about ergonomic setup, as well as the importance of intra-op micro breaks, and then end up with some take-home points, and hopefully we'll have some time for questions afterwards. So let's get started. What is ergonomics? It is the study of human work and how it relates to our environment. And with the goal being that we want to reduce the incidence of work-related musculoskeletal disorders. A lot of you, when you started your work as a resident or a fellow, may have gotten some requirements at your hospital about even how to set up your workstation ergonomically. This is done at a lot of places. But surprisingly, as physicians, we probably did not spend, we spend majority of our time not in the work with this as our workplace, but in the OR. And we don't get enough education or assistance with how to set up our workspace in an ergonomic setup. But the principles remain the same. You want to keep the monitor at eye level or just below, and about 2 to 3 feet away or about arm's length. You want to have minimal bend at the wrist when you're doing any type of work. Keep your back straight, your elbows close to your body with some sort of support for your lower back. And keeping that hip at about 90 degrees or slightly more, but not flexed. And lastly, you don't want the seat of your chair pressing to the back of your knees with your feet flat on the ground. And if you think about it, this position is probably the same position you want to be when you're at the console doing a robotic procedure, or when we're sitting down doing a TAMIS procedure. So this brings to front the principles for ergonomics, which is working in neutral positions to reduce excessive force and keeping things in reach. You want to work at the proper height and reduce excessive motion to minimize fatigue and static load. You want to minimize pressure points, provide adequate clearance to be able to move, and then also find time to exercise and stretch and make sure your work environment is comfortable. And the reason is that without ergonomics, surgery can be significant pain. In a meta-analysis published by Stuckey in 2018 in the Annals of Medicine and Surgery, looking at 41 articles involving 5,100 surgeons, over 2/3 suffered from pain during operating, with another significant number having fatigue, and about 37% experiencing numbness and stiffness, with the involved joints being the back, the neck, and the arms or shoulders. Mostly it is because the way we practice surgery violates the principles of ergonomics, whether it's a consequence of surgical culture, the instruments that we use, which are not designed for surgeons, but designed for ease of processing. They were initially designed for bigger hands, the use of multiple adjuncts such as headlights, loops, and aprons, the addition of digitation of non-operative tasks, as well as workspace and time restrictions have all contributed to the increase in work-related musculoskeletal disorders. For those who are performing a lot of laparoscopy, and we'll also talk about robotic surgery in a bit, this survey of gynecologic surgeons published in 2016 showed that out of 100 surgeons, 77% reported symptoms of their thumb, shoulders, wrists, fingers, and elbows. And particularly for colorectal surgeons who perform a significant number of endoscopies, the study on the entire GI team involving the gastroenterologists, nurses, and technologists experience significant percentage of pain in their neck, lower back, hands, shoulders, and thumb, as well as their elbows and carpal tunnel syndrome in a significant manner. And so this just goes to show that every single procedure that colorectal surgeons are doing probably contribute to additional ergonomic challenges. And even looking at those who may opt not to perform endoscopy in the future, even just it just goes to show how much of a burden endoscopy adds to your practice. You can see here the significant difference in hand pain, back pain, leg pain, and wrist pain of a gastroenterologist perform endoscopy versus those who don't. So this just highlights that adding endoscopy to your armamentarium as colorectal surgeons also adds additional ergonomic strain to your body with no significant variables other than probably accumulative years in practice over time. In the OR, operation-related musculoskeletal injuries have resulted in over 50% of injuries in this survey conducted by plastic surgeons. Published in the Plastic Reconstruction Surgery Global Open Journal. They looked at multiple specialties, including general surgery, CT surgery, and colorectal surgery. And this showed that of practicing surgeons, both on the male and female side, experienced musculoskeletal injuries. However, what was interesting was that the onset of injury was higher at a lower age for female surgeons. As you look at this graph, you see there that in blue, the female prevalence of musculoskeletal injury was higher at lower age groups, and will probably affect the longevity of female versus male surgeons long term. So I just briefly went over some of the issues as well as the principles and definition of ergonomics, and I will transition to more significant things as to why this is important. This illustration here shows just how interconnected surgical ergonomics is with everything that we do in surgery, whether it's productivity, career longevity, teaching, communication, teamwork, intraop stress, finances, patient safety, and quality of patient care. Surgical ergonomics somehow at one point or another will be affecting this at various stages. In terms of quality of care, again, the same paper from Stuckey showed that about 30% of surgeons take their symptoms into account, and this may result in a change to the procedure to reduce the pain of an operation, whether it was open or a minimally invasive procedure. For trainees who often work long hours under sleep-deprived conditions and are usually the most junior personnel in the room with little to no input on room setup, having significant issues with setting up the room can then lead to more injuries as trainees generate more force than necessary and move or maintain suboptimal biomechanical postures more frequently. And then once in the role of an operating surgeon, the position of either the operating room table may not be, or the monitors may not be optimized, may be optimized for the attending surgeon, creating additional physical and cognitive ergonomic stress for the trainee. And more often than not, a lot of trainees are not aware of ergonomic principles. And the long-term significance of this is degenerative spine disease, rotator cuff pathology, degenerative lumbar spine disease, and carpal tunnel syndrome, as well as a reduction in surgical workforce. Approximately 12% of the surgical workforce are expected to leave practice as a result of work-related musculoskeletal disorders, leading to either practice restriction modification or early retirement. Now we get into the meat of this talk as to how can you set yourself up for success ergonomically in the various procedures that you do. So one of the things we have at UCSF is this safety checklist that we use, where we talk about the surgeon gives their introductions, goes over patient characteristics, and then anesthesia and circulating nurse and the scrub person also introduce themselves and talk about any questions or concerns. I think at this point, it's time to think about whether it is appropriate, and I do believe it is, to also talk about an ergonomics timeout in the OR. And when we talk about an ergonomics timeout, we talk about things in our head, for example, the lights, the monitors, the loops. And then for our torso, is it the proper table height for the tallest person in the room? how the cords are thrown off the table so that they do not obstruct or cause injury, making sure that we have proper retractors and instruments that are correct for our size hands, and the use of anti-fatigue mats, proper positioning of pedals, and the use of step stools. So let's go over some of these things in greater detail. So for table height, it is very important to plan the height of the table based on the tallest person involved in the procedure, whether it be the scrub tech, the medical student, or the attending. Take into consideration the size of the patient and use locking step stools with anti-fatigue mats when available. Make sure overhead lights are positioned between members of the team to avoid head shadows, to avoid eye strain, as well as craning your neck to be able to visualize things better. And some of these recommendations are from the American College of Surgeons Division of Education and Surgical Ergonomics Committee. When choosing instruments, use ones that lock to minimize grip fatigue, and as much as possible, use self-retaining retractors and powered tools or staplers when available. Think of working in a box when looking at your hands and elbows. Keep your wrists straight with elbows near 90 degrees. Your arm should not cross the midline, and avoid twisting or reaching the end, or trying to avoid reaching the end of range of motion. Use body supports and avoid prolonged sustained postures or static postures, particularly when retracting. As colorectal surgeons, you guys wear a lot of things in your head, whether it be loops, headlamps, or sometimes even a head-mounted camera. And all of these things add additional weight. You probably heard of the term cell phone neck. And if you apply the same principle to operating with each additional 5 to 10 degrees of forward flexion, you can see here that this puts a significant strain on our necks in terms of the amount of weight that our cervical vertebrae are carrying. In addition, for those who are wearing loops, consider wearing a loop with a declination angle so that this changes the degree of flexion of your neck, as this can play an important role in developing significant cervical neck disorders. The use of step stools, ergonomic anti-fatigue mats, and positioning your foot pedals on another step stool is very important to avoid having to put additional strain on your legs because you are distributing the weight of your feet when operating. And then this is actually a very interesting and very educational work from the core curriculum for ergonomics and endoscopy by the ASGE group led by Kathy Walsh. They talk about how to position the bed, the monitor, and the endoscopy tower to minimize long-term fatigue, especially for colonoscopies, as this produces a significant strain on your body. Making sure that the endoscopy tower and the monitor are in line so that there's minimal strain on your shoulders. Some studies have shown that women suffer more carpal tunnel and finger and wrist soreness, while male endoscopists suffer more back and neck pain, probably because of how torque is being achieved during colonoscopy. Looking at the height of the hospital bed, you want that height of the bed to be about 10 centimeters below your elbow, so that there is minimal excessive flexion or extension of the elbow. And there now are scope holders so that when you're performing additional procedures, that scope can be held, the scope head can be held in place to avoid the additional strain that it causes by keeping it elevated. In terms of laparoscopic surgery, you want to avoid extreme flexion or extension of your shoulders, elbows, and wrists. You want to really keep your head over shoulders with your chin tucked about 15 to 20 degrees, with the shoulders over your pelvis, with your feet at hip width, and keeping your monitor about 2.5 to 3 feet away with a 15-degree gaze down. You want to lower that table height so that laparoscopic instruments are held below shoulder height. And these are the materials in your SCORE curriculum that were jointly produced with the SSE. And the same principles apply to TAMIS. Whether you are in a standing position, you really want to maintain that head at a neutral position with about 15 degrees downward gaze, keeping your monitor about 3 feet away, and adjusting the table height depending if you prefer to do this procedure sitting or standing, as is shown in this diagram. You really want to avoid extreme flexion or extension of your shoulders, elbows, and wrists, and really lower the table height so that your laparoscopic instruments are again held below shoulder height. As we know, more and more procedures are now being done robotically. This illustration from the Mayo Clinic, produced by Sue Halbeck, who is now the president of SSE, has been very helpful. This came from a interventional study of from JMIG by Halbeck and Hookenstad, just as to how to properly adjust your console. And the important thing is you have to first have the proper chair. Make sure adjust your hair to match your proper popliteal height, because this is really the start of everything. If you don't have the proper chair, you're going to have challenges at the console. So before you even sit down, raise the console all the way up, rotate the console towards you as far as it can go, lower the armrest all the way down, and retract the foot pedals away from you all the way into the tower. And then slide in with a proper chair, adjust it to your popliteal height, move the chair as close to the armrest as possible, and raise it for clearance. Then sit up straight and lower and rotate the console until able to see through the viewfinder. Afterwards, hold the controls and keep your arms close to your sides, raise the armrest, and then place your foot on the pedals and adjust the pedals as necessary. And again, the principles remain the same, keeping your back flex neutral if possible, but you can also lean forward to a maximum of 15 degrees. Keep your head, your elbow angle at about 90 to 120 degrees to your shoulders. Keep your thigh parallel to the floor, and have minimal flexion of your foot when controlling your foot switch, and keep your feet on the floor to an angle of at least 90 degrees. You want to keep your stereo viewing angle to less than 30 degrees from the vertical, and always be clutching, which is what I tell my residents, ABC. Always be clutching and keeping your hands and wrists neutral in a sweet spot. And this can really lead to significant lowering of the soreness that you experience. As you can see in the smaller chart, in an assessment of surgeon physical discomfort during robotic-assisted surgery, 21% experience neck discomfort, 20% experience finger discomfort, and a smattering of wrist, lower back, upper back, shoulders, and eye discomfort. So all of these things matter when you're setting yourself up on the console. Additional strategies, and this is why I was asking earlier at the very beginning, do any of you stretch or exercise before, during, and after surgery? Because warm-up exercises prior to surgery can improve performance and decrease strain. Intra-op micro breaks, which we will finish the talk with, and stretching can improve discomfort, reduce eye fatigue, and improve surgical performance. And regular exercise can decrease the risk of injury, while strengthening exercises can help prevent pain and discomfort. Very important to seek help when symptoms develop, and being aware of your poor posture and actively correcting when recognized, aka postural resets, and also adopting good posture outside the operating room, whether working on a computer, using a tablet on a couch, or walking around while using your cell phone. So last but not least, we'll talk about micro breaks. Micro breaks are very targeted short physical breaks that are done every 30 to 120 minutes in the middle of surgery. Surgeons are reminded to do this every now and then with a timer so that the stretches can be performed in the sterile field at the OR table. and targeting the back and the neck for those that are shorter. This two charts show two types of stretches, one being performed standing and the other one being performed seated. Those charts are available to be downloaded from the Society of Surgical Ergonomics website. So take-home points to consider. Think about ergonomics of the entire team, the surgeon, the assistants, the students, and the scrub tech or the scrub nurse. Have situational awareness for all the peripherals involved during a case, including your overhead lights, your headgear, and your footgear, and proactively engage in pre, intra, and post-case stretching and micro breaks. Thank you so much for your time. I just want to do a quick plug. Please scan this QR code. We are doing a study right now to understand the interplay between surgeon hand size and handling of surgical instruments. So please take a photo of your hand with a room key or credit card at the bottom of your wrist and upload it to this website. And these are some of the links to help with getting copies of some of the materials that were included in the stock. Thank you so much to Colorectal Surgery Virtual Education Seminar Series, and looking forward to take any of your questions.
Awesome. Thank you, Dr. Soriano, for that talk. Just as a reminder to everybody watching, if you have any questions, comments, or thoughts, please feel free to post in our chat here or in the Surgeon chat, and we'll happy to filter those questions in for Dr. Soriano. It looks like Stevie J. Stapler's got one, which is earlier we mentioned having appropriate retractors or tools for hand size. Do any instruments for smaller hands come to mind? And Stevie J is a smaller hand size herself, as am I. So definitely would like to know the answer to that.
Yes, Stevie, thanks for your question. So a lot of the instruments, as you all know, were designed for when the average surgeon size hand was about 7.5 glove or a 7 glove. That is why having a powered instrument or a locking instrument is quite helpful. And we are now actually, the SSE is working with a couple of surgical companies in designing instruments that are more appropriate for surgeons with hand or glove sizes smaller than a 6. In addition, it might be good to talk to your OR team and see if they have any sets that are specifically designed for smaller hands, because some of your attendings, whether it be in general surgery or in other fields, may have requested for specific instruments that are made for smaller glove sizes, smaller hands. So they all actually already might have some instruments that you're not aware of that are specifically designed for smaller hands. So I think those are the two things that are important, knowing what your hospital has. And then second is using powered and locking instruments or staplers.
Awesome. There's another question in here. This is a tricky one. Sometimes it's hard to provide feedback to our attendings in the OR regarding ergonomics. Are there any tips about how to approach this?
So one of the things that I think is important to discuss with the attending is maybe ask them, how long they've been operating, and have they always set things up the same way, and have they experienced any kind of back pain, muscle aches, joint pains, and so on and so forth. So bring up the topic of ergonomics, I think is one way to discuss with the attending how setting up the room in a way that benefits everyone is one way to go about it. At UCSF, I gave grand rounds to the Department of Surgery, and some of the other attendings, for example, in plastic surgery and ENT have done something similar. See if you can identify a champion at your hospital or program, not necessarily in your department, who may have given talks on ergonomics, and it might be inviting them to give grand rounds, or anyone from SSE, for example, to come and give grand rounds at your hospital or program might also be very beneficial to raise importance and awareness of this. The ACS has actually released a couple of bulletins on ergonomics, and so that might also increase their awareness of the importance of how to properly set up a room so that the ergonomic benefits are experienced by everyone and there's no discomfort because of how the room is set up.
Great. Got another one here. Thank you so much for this talk. This topic is crucial to our longevity, which I think we all can agree with. Do you know of any companies in specific that may be open to allowing trainees to try out newer or lighter or more ergonomic headlights, for example, as hospitals may not be willing to invest in purchasing these for trainees?
So we are, the SSC has a committee that actually works with industry, and we've been helping them with designing, at least for those who are open to redesigning some of their instruments to make this more user-friendly or more user-centric than just thinking about designing an instrument without taking into account the number of users who might be affected by their design. I do not have specific companies to name at the moment, but we are working with a couple of companies within our society, and I think more and more surgical device companies who attend, whether it's ACS, SAGES, ASCARS, and other large society meetings, are seeing the benefits of redesigning their equipment geared towards a more ergonomic design, especially for smaller gloves. And I think that is why that the second to last slide or last slide showing the QR code is going to be helpful in gathering data to prove and show these companies that, you know, the most common glove size now is not an 8 glove or a 7.5 glove, but we're probably closer now to 6.5 or 7 because of the increased number of females or women in surgery, the increased number of non-Caucasians in surgery. So we are seeing a increased number of smaller glove-sized people in our practice. And we're not just talking about surgery here. We're talking about GYN. We're talking about ENT. We're talking about the procedurists. So all of the practitioners in all these various fields are seeing more diverse population of practitioners. So it's very important to take into account all of these glove sizes in developing all these new devices.
Awesome.
I'm happy to put the QR code again.
Yeah. Perfect. A couple other questions I've got here. Do you have any tips, tricks, or pointers for ergonomic things we can do to be more ergonomic during endoscopy?
Yeah, so I showed the slide earlier, and I'll go back to that. So here, again, it's very important that it starts with the bed that you're using, right? So if your hospital, if the stretcher you're using cannot go all the way down to such a point where your elbow is at a neutral position, you need to use a step stool with an anti-fatigue mat. This is probably the single biggest investment that your endoscopy suite should have, so that when you're standing there doing colonoscopies, doing interventional endoscopy procedures, multiple biopsies, and then the second one would be using a scope holder, so that you don't have to keep that scope in your hand, holding that scope in a prolonged position, resulting in fatigue and discomfort of your left elbow. And then the second would be also decreasing your eye strain. Don't make sure that monitor is not too far away from you, and keep that in the proper height. Most of the older endoscopy suites were designed, in a piecemeal fashion, so things might not be set up this way. But to have a prolonged career, and when you're looking at places to take a job in, look at how they designed their endoscopy suite, and making sure that you're able to perform 5 or 10 or however many colonoscopies within that time frame that you need, in a way that you're not beat up and tired at the end of the day. So set up your endoscopy tower in such a way so that that cord that holds your scope is not too far away, because that puts added strain on your arm and your shoulders. Using your tip for torque steering, and see here how you have your wrist in a neutral manner when you're doing that, so you're not fatigued at the end of the day.
Awesome, thank you. And that actually is a good segue into the last question I've got for you here, which is, as many of us are looking for jobs and engaging in contract negotiations and thinking about what to ask for our, future employers, what's reasonable to talk about or ask about in terms of concessions or things that we should request up front to help with improving our ergonomics before we get started?
Yeah, I think important to have, for example, for headlights, having the lightest set of headlamps that you can use available, so it's not putting additional strain on your necks. And then ensuring that whether it's the endoscopy suite or the OR, having anti-fatigue mats and step stools available, because the adjustable height beds will be there. But if you don't have the anti-fatigue mats and step stools, that might place an additional strain, especially on the shorter surgeons when you're setting up to do an open or laparoscopic case. The towers, for the most part, make sure that they are working properly. I have to admit that some of the places I've been to working, the monitors do not come down as high as, do not come down to my eye level. And so rather than, what I do at that point then is I actually elevate the bed and I put additional step stools, even if I don't have to, just because I can't get the monitors down to be at the same height as that I would want it to be when I'm operating. And this would probably be at older institutions. So, this all adds to career longevity, as Vanessa stated in her question. And so it is important that when you're looking at new jobs, to see how ergonomics is taken into account in the OR, in the endoscopy suite, and make sure that some of the adjuncts that we mentioned here are already in place, or that they will stock them and have them available, whether it's powered staplers, powered instruments, locking instruments. Some of the laparoscopic instruments might not be available there that are rotating. So you want to make sure that the laparoscopic instruments are also rotating, because they will add strain to your operative to your body as well when operating.
Awesome. Thank you very much, Dr. Soriano, for taking the time to talk with us. This has been incredibly helpful, practical information for everybody. Please tune in, everybody, next week. It's Sunday, 7 p.m. And visit our website at crsvirtualed.org if you're interested in looking up our upcoming talks. Thank you again, Dr. Soriano, and everybody, for tuning in, and have a good night.
Thank you so much. Have a good night, everyone.